Yes, you can start, sir. 5, 4, 3, 2, 1.
Hello friends, today I will be speaking on role of interventional pulmonology on tuberculosis. The various indications of the bronchoscopy in tuberculosis can be broadly classified into those which are used for diagnostic purposes and those which are used for therapeutic. The various diagnostic modalities which can be performed with bronchoscopy are BAL, endobronchial biopsy, transbronchial lung biopsy, radial EBUS, conventional TBNA, and EBUS TBN. The various therapeutic procedures that can be performed include tuberculosis associated tracheobronchial stenosis, management of massive hemopsis when you are buying time for the patient to undergo a bronchial artery embolization, or in few cases of prolonged air leak with bronchopleural fistula following a tuberculosis. Before I go to the topic proper, I will discuss a few points about the tracheobronchial tuberculosis. So tracheobronchial tuberculosis, which is otherwise referred to as the endobronchial tuberculosis, is a tuberculous infection involving the tracheobronchial tree, and it requires both microbiological and histopathological confirmation of tuberculous pathology in the biopsy. And it generally occurs in females, most commonly in second to third decade, and left bronchus is more commonly involved in patients with endobronchial tuberculosis. There are various pathogenesis mechanisms which has been postulated, and they are the direct infiltration of the disease from the lung, the infected sputum or the secretions, which causes a direct implantation of the organisms in the tracheal or in the bronchial wall, hematogenous spread, lymphatic dissemination, and erosion of the lymph nodes into the trachea or the bronchus. So next important question is why we have to consider the role of an interventional pulmonology in endobronchial tuberculosis. This is because the goal of the treatment of any tuberculosis patient is eradication of the tubercle bacilli as well as the prevention of the most undesirable consequences. But however, it has been found that the ATT chemotherapy is not successful method in preventing the residual tracheobronchial tuberculosis. That is why few of the patients rather, land up having a tracheobronchial stenosis. So in a study by Chung et al., it has been found that the persistent bronchostenosis was observed in as high as 41.8% of patients of tuberculosis. And even in the pharmacological management, there has been few case reports about the role of the oral corticosteroids, but even now it is considered to be a controversial thing. This is because in a study by Shim et al., he found out that when prednisolone 1 milligram per kilogram is given for 4 to 6 weeks and was further tapered over another 4 to 6 weeks in patients with edematous or hyperemic endobronchial TB or caseating and tumorous types of endobronchial TB, there was definitely a benefit in the outcome. But however, other studies have found out to be no benefit. So oral steroids is not the final solution for treating a patient with endobronchial tuberculosis. So when do we really consider endobronchial tuberculosis? So any patient of tuberculosis who presents with severe cough, sputum, wheezing, hemopsis, or paroxysmal dyspnea, you should have a high suspicion of endobronchial tuberculosis in them. Moreover, when you do a PFT for some other reason, even in the post-treatment, if you find an obstructive pattern, probably the patient can have a sequelae of an endobronchial tuberculosis in the form of a bronchostenosis. This brings us to the next important question, like when do we suspect tracheobronchial tuberculosis on a radiology? So when you get an X-ray and you see that the lung is totally collapsed, in a patient who is either taking ATT or who has completed the course of ATT, you should have a high suspicion of endobronchial tuberculosis. The other is when you see a CT scan, in your cuts, if you see that the lumen of the bronchus is decreased or narrowed or stenotic, then you should have a high suspicion of the patient having an endobronchial tuberculosis. So what is the role of the bronchoscopy in patients in whom you suspect an endobronchial tuberculosis? So there has been a bronchoscopic classification of endobronchial tuberculosis. The first picture is the actively caseating form of an endobronchial tuberculosis, while the second picture is a edematous or a hyperemic form of an endobronchial tuberculosis. And you can have a fibrostenotic type, you can have a tumorous type, you can have a granular type, you can have an ulcerative type, and even non-specific with just erythema and edema. And the most important thing is your bronchoscopy can help in your prognosis. This is because most of the endobronchial tuberculosis happens in the first 3 months of treatment. and later it may result in a persistent and a permanent damage. So you should actively look for a presence of an endobronchial tuberculosis, and if there is any, you should effectively treat it. And these therapeutic outcomes can be followed up with the help of a bronchoscopy, which are performed in the first 3 months of the therapy. And the fibrostenotic, the actively caseating, the edematous hyperemic, and the tuberous endobronchial tuberculosis have the worst prognosis. So doing a bronchoscopy in these patients, one, can help you in diagnosing endobronchial tuberculosis. Number two, it can give you some idea about the prognosis of and the outcome of the patients with endobronchial tuberculosis. So this brings us to the next question. What is the role of a bronchoscopy in diagnosis of a sputum smear negative or a sputum scarce TB patient? As we all know, BAL is one of the modalities which we commonly use for a patient who has a smear negative tuberculosis, and it has been found that approximately more than 50% of the pulmonary tuberculosis is sputum smear negative, and it is more so in patients with immunocompromised condition. And if you do not diagnose these patients properly as tuberculosis, there may be a diagnostic delay which may increase the probability of a poor prognosis, leading to increased morbidity, mortality, economic burden, and Mycobacterium tuberculosis spreading in the community. So the sensitivity of the BAL and the bronchial wash with smear microscopy is only between 4.7 to 58%. So your smear microscopy cannot alone help you to diagnose a tuberculosis very well. So then came the gene expert. The sensitivity is as high as 83 to 100%, and the specificity is 97.7 to 100%. So these days we are coming up with the gene expert ultra. So is there a real difference between a gene expert and a gene expert ultra and a BAL? So one study was published in the pediatric population where it was found that the gene expert ultra had a very high sensitivity of 91% against a microbiological reference standard, while the gene expert had only 80% positivity. The ultra was positive in 58% of the children who were clinically diagnosed with PTB, in whom even the culture was negative. So it was still a true positive. And 71% remained ultra positive even after 2 months of tuberculosis treatment. That means you cannot follow up the treatment response with gene expert ultra. And 3 case patients with NTM, non-tuberculosis lower respiratory tract infection, in whom ultra results were positive. So that means there can be a possibility of a false positive ultra as well, because it has got a very high sensitivity, but the specificity is less. So then comes the role of the transbronchial lung biopsy in the diagnosis of TB patients. The transbronchial biopsy mainly helps to rule out the mimics of tuberculosis. One, malignancy, another, fungal infections. And even in immunocompromised, it can help you to get an idea about an opportunistic infection. It has got a sensitivity of 16 to 77%, and the complications are pneumothorax and bleeding. So when TBLB is combined with a radial probe EBUS, the sensitivity can range between 32.9% to 77%. However, in high TB incidence country, the ultra thin and the standard scope did not differ in their yield. So you can still use a standard scope to diagnose to carry out a transbronchial lung biopsy. And TBLB also provides a rapid diagnosis in miliary TB. In smear negative miliary TB, the yield of a TBLB ranges between 60 to 80%, and the culture of the TBLB and the bronchial brushing further enhances the yield. So when you send a biopsy for histopathology, do send culture and the bronchial washing as well. And newer advancements has come in this TBLB with the assistance of navigation, radial EBUS, and cryobiopsy. So the most important factors which affect the sensitivity of the transbronchial biopsy are the lesion size. Higher the size, better is the sensitivity. The presence of a diffuse disease in the form of miliary tuberculosis, and the assistance with the radial probe ultrasound. So this brings us to the next question. Is there a role of a radial probe EBUS in diagnosis of TB patients? This is mainly used in case of a peripheral lung lesions. Any lesion that cannot be seen visually with a bronchoscope, we call it as a peripheral lung lesions. And in TB, it can present as a peripheral lung lesions, which may be even an active infection, or it can be a tuberculous granuloma, or it can be even an inflammatory scar. And in India or any TB high endemic countries, you cannot follow with the routine protocol for a solitary pulmonary nodule because there is a difficulty with radiological surveillance. And delayed diagnosis and empirical tuberculosis treatment will lead to increased drug resistance, increased morbidity, and mortality. And percutaneous lung biopsy and surgical resection, which are tried for peripheral lung lesions are associated with a high procedural risk. And so this brings us to the options with bronchoscopy, which can be in the form of either a radial EBUS or in the form of a navigation bronchoscopy. So if you look at these CT pictures, these are not classical of tuberculosis. Many of them mimic either a form of an aspergillus or mimic a form of a cavitating malignancy, or multifocal consolidations or multifocal nodular lesions, mass-like lesions, spiculated lesions. But end of the day, all this turned out to be a tuberculosis on biopsy. So it is always imperative to make a diagnosis of tuberculosis before you start the patient on empirical ATT regimen. So this brings us to the role of the radial EBUS. So the radial EBUS is a procedure that shows the lung images around the bronchus by transmitting the ultrasound signals generated at the endoscopic ultrasound center to the miniature probe through the driving unit. So the first picture shows the probe, shows the processes, and the second picture shows the probe within the bronchoscope, and the last picture shows how we put the radial EBUS into the bronchus. So these are the images which you will get in a radial EBUS. The first one shows a concentric image. That means that there is a center bronchus and surrounding it is either the TB or the tumor or the consolidation. And the second image shows the eccentric. That means the tumor or the lesion is not entirely encircling the bronchus and it is eccentric in nature. In these cases, even cryobiopsy with the help of the radial probe can give us a better yield. So there was a study of the radial EBUS in diagnosing peripheral lung lesions in high tuberculosis setting. It was found that the sensitivity was 77.3%, the positive predictive value of 100%, the negative predictive value was 95.2%, the diagnostic accuracy was 95.8%, and 58.8% of pulmonary TB cases relied on histology to make an early diagnosis. So in conclusion, they said that the radial EBUS gives a more rapid diagnosis technique for tuberculous lesions, which are mainly peripheral lung nodules. So what is the role of a convex EBUS in tuberculosis? So I'll just give few points about tuberculosis. The most important thing, what we really see is whether it is a tuberculosis or a sarcoidosis. So this was a study which was done by Duria et al. Of 165 patients, where they found out that if a node is having a heterogeneous echo texture or a positive coagulation necrosis sign, and the patient is having a positive MON2 test, then there is a very high possibility that this is a tuberculosis. In addition to this, you can use the presence of the gene expert to confirm if it is a tuberculosis. And another important aspect which is coming is whether these nodes, which even after multiple times of ATT intake continues to persist or even increase in size. So what are they? So a study was done to assess the presence of a multi-drug resistance in tubercular mediastinal adenopathy by convex probe EBUS. In this study, they found out that the overall incidence of MDR was 77.8%. And in a new case, the incidence of MDR was 2.2%, and in retreatment case, it was as high as 46.1%. So, but however, they said that this high number in comparison to the previous study, which quoted roughly between 20 to 30% of MDR in a nodal TB, may be due to the small size of the sample, which is only 1 or 2 patients. In addition to this, as we can see, even the individual drug resistance, the INH was seen in 16.7, rifampicin was in 7.8, ethambutol was 10.8, and streptomycin was 23.5, suggesting there can be presence of both monoresistance and even MDR in these lymph nodes. So there are also multiple papers suggesting about the role of an EBUS in differentiating tuberculosis from an NTM, which is very common in an immunocompromised patients. So this was a study published in European Respiratory Journal, where they analyzed 2,539 EBUS cases, and among the 26 were suspected to be TB, for which EBUS was done, and they found out 33% of the samples were sent for mycobacterial culture and 21% came positive for MTB, while 2% had positive cultures for NTM. So even your nodal TB can be because of your non-tubercular mycobacterium, and your convex EBUS helps in diagnosis. And the most common organism was Mycobacterium avium intracellulare, the other are Kansasi, Malomyces. There were also other common cells like Chelone, Gordone, and Mucogenica. So what is the role of cryo in tuberculosis? A cryobiopsy in tuberculosis, there are only very few case reports and abstracts. It may help in miliary tuberculosis and in ruling out alternate diagnosis, but however, you cannot send a cryo sample for tuberculosis culture. And the complications are bleeding, especially more in patients with pulmonary hypertension and pneumothorax. So this is how we do. We do it under a fluoroscopic guidance. A cryoprobe is passed and a Fogarty or any endobronchial blocker is kept. Once the cryobiopsy is taken, the blocker is inflated to prevent flooding of the airways. So the role of the cryolung biopsy in tuberculosis, there was a study which was published in ERJ about the role of cryobiopsy in diagnosis of smear negative pulmonary tuberculosis. It was found that in biopsy, TB granuloma was seen in 20.8%, while interstitial pneumonia in 16.7%, and non-specific inflammation was in 37.5%, and healthy lung tissue was in 25%. The complication included bleeding, which may be mild, 95.8%, moderate in 4.2%, and pneumothorax in 8.3%. This is just to show how cryo can also help in ruling out other diagnoses. A patient was presented with 60-year-old alcoholic diabetic with fever, cough, loss of appetite, and loss of weight, treated with empirical TB, no response. FOB was done, which was suggestive of a pus oozing from the left upper lobe. All the cultures were negative, including the gene expert. Cytology was negative for malignancy. So there was a thick material that was seen, which we attempted a cryo extraction of this mass-like lesion. In the end, it turned out to be an invasive mucormycosis. So your cryo can also help in diagnosing alternate conditions in a patient who is on ATT and not responding to treatment. So this is another role of a cryo, where a cryo can also help in taking endobronchial biopsies of these tumorous forms of your tuberculosis. And it has been found that the broncoscopic cryotherapy can accelerate the healing of a granular endobronchial TB and help to prevent progressive bronchial stenosis due to granular endobronchial TB. And it is considered to be a relatively safe method. And moving to the last but one part of my presentation, the role of the thoracoscopy in tuberculosis. We always rely upon ADA and the lymphocytic ratio to be very high positive, but there are some problems associated with ADA. It may be false negative in the early phase of the disease and elderly and even in current smokers. And it can be false positive in rheumatoid effusion, empyema due to other bacteria, mesotheliomas, lung cancer, parapneumonic effusions, and hematological malignancies and immunocompromised condition. The other problem with the pleural TB, it's a paucibacillary. And there are case reports that pleural TB can present as primary MDR TB, where monoresistance was observed in 11%, MDR was observed in 3%, and XDR was observed in 1%. And your thoracoscopy can help in both diagnosis as well as in therapeutic. And one of the most important thing, what we fear about pleural TB is the residual pleural thickening. And it has been found that a residual pleural thickening of greater than 10 millimeter was seen in 20 to 46% of patients who had a prior TB. And this impaired their quality of life with chronic chest pain, dyspnea, and impairment in the lung function. The other complication of this pleural TB is the fibrothorax. And there are few case reports which have said that the early drainage of the loculated pleural effusion in tuberculosis will help to decrease the pleural thickening, though it is still under a research topic and still the management is controversial. So this is one of the slides where you have a clinical and radiological suspicion, you do a thoracosynthesis, you are in a high TB setting condition, and you have a lymphocytic effusion with an ADA greater than 40, well and good, you treat it as tuberculosis. If it is not, you again go for a repeat thoracosynthesis, and if it is still ADA is low, then you should consider for a pleural biopsy. On the other hand, if you have a low ADA and a lymphocytic effusion, you should always go for a pleural biopsy. So your thoracoscopy can help in diagnosis of tuberculosis and also in ruling out malignancy. So these are the various patterns which you can find in a medical thoracoscopy. It can be a free-flowing fluid, it can be a fibrinous exudate, it can be an adhesion, or it can be even a caseous form. So this study was conducted to find out whether the tube thoracoscopic drainage of the fluid, whether did it have any benefit in comparison to the pigtail catheter or with the large bore tube. So in the end, they found that the medical thoracoscopy showed significant efficacy in the group of multiloculated effusion and organized effusion, but not in a free-flowing effusion. And no chronic morbidity and mortality related to the complication was observed and the authors concluded that the medical thoracoscopy was a safe and a successful method in treating multiloculated and organized tubercular pleural effusion. So this thoracoscopy will also help to increase the histology, will increase the microbiological diagnosis of the tuberculosis. This was a study undertaken in India, where they have done a thoracoscopic pleural biopsy along with a gene expert. They found out that the histopathology was diagnostic in 100% of the patients, and pleural tissue gene expert had a sensitivity of 45%, and pleural tissue culture had a sensitivity of 39%, while pleural fluid culture had only 17% sensitivity, and pleural fluid expert had only 14% sensitivity. So thoracoscopic pleural biopsy resulted in an increased sensitivity on expert testing in pleural tuberculosis. Last topic, which is the role of a navigation bronchoscopy in diagnosis of TB and complications. So there are few case reports which are coming in the use of the navigation bronchoscopy for accessing the peripheral pulmonary nodule. So this study was taken where 70.5% of the cases were pathologically or bacteriologically confirmed when radial EBUS was used along with electromagnetic navigation bronchoscopy. And among patients with the final diagnosis of pulmonary tuberculosis, 56.8 were confirmed with the help of an EBUS plus electromagnetic navigation bronchoscopy. But these advanced procedures should be used only when there is a difficulty in accessing with the help of a radial probe EBUS. And this is one another utility of your virtual bronchoscopic navigation, where if you want to know what is the size of the stenosis, what is the length of the stenosis, and if you want to know what is the condition of the lung segments beyond the stenosis, the navigation bronchoscopy may help in diagnosing. So it will not only show the length, it will also show whether the bronchus behind the stenosis is still patent or not. And there is an excellent correlation between a real-time bronchoscopic imaging and the values obtained by the navigation bronchoscopy in identifying the length and in the size of the stenosis. So VBN is helpful for diagnosis of tuberculosis stenosis, tuberculosis-induced central bronchial stenosis. It may provide information on the location, morphology, extent, and the degree of stenosis. For further bronchoscopic examination and interventional therapy is recommended for patients with tracheobronchial stenosis, and VBN is recommended for those with contraindications to bronchoscopy and for regular follow-up patients with tracheobronchial stenosis. Thank you.